Good morning. This is really exciting to me. We actually have people who've come down to sit closer to the front today. We've got a bigger audience than usual to begin with. So I'm going to have to do some research to figure out what it is that got you here. I could go to KJ Freeman, but you know, she comes, well, I can maybe remember the last time she came to Grand Rounds. But be that as it may, it is exciting to have you here. As you know, we're continuing our group of Sconyers Godfrey ethics lectures. Maureen Kelly is going to be the moderator, and we'll be introducing the team to do that. Maureen?
Good morning, everyone. Thank you for coming. We have an exciting presentation today, a controversial case that we've all wrestled with. Before we get started, I just have one quick announcement, a reminder that our Truman Cats annual conference will be this July 19th and 20th at Bell Harbor. And this time, rather than pick a theme, the title of the conference is Cases That Keep Us Awake at Night, Challenges in Pediatric Bioethics. So we've got some doozies that we've all wrestled with from across the country, and we think it'll be a really exciting conference. We hope you can make it. Information's on the website. So the topic for today and the case for today is definitely a case that still keeps a lot of us up at night. It's based on a real case. We've changed some of the details to protect the family and the patient, but that we've had a series of maybe 5 or 6 cases of solid organ transplant where the parents have refused the transplant, where the team felt strongly that the transplant was best practices, best option for the child, that the prognosis was good. And so as a hospital, we've really been wrestling with this question, and we thought we would feature a case that was a bit of an amalgam for Ethics Grand Rounds to prompt discussion about some of the ethical challenges inherent in these cases. From the transplant team, presenting the case will be Dr. Patrick Healy, Associate Professor of Surgery and Chief of Transplantation here at Seattle Children's, and Dr. Evelyn Sue, Assistant Professor of Pediatrics, Gastroenterology, Hepatology, and also from the transplant team, and just finished a transplant at 5:30, is that right? So thank you for coming. And then visiting us from Connecticut, from Yale, is Dr. Mark Mercurio. And he's our pediatric bioethicist who will be commenting on the case and offering some of his thoughts before we come back and tell you the outcome of the case. Dr. Mark Mercurio is director of the Program for Biomedical Ethics and Pediatric Ethics at Yale. He's professor of pediatrics at Yale University School of Medicine, attending neonatologist at the Yale New Haven Children's Hospital. He directs education, medical ethics for the School of Medicine and the pediatric residents and fellows. He's chair of the Pediatric Ethics Committee at the hospital, associate director of the Yale University Interdisciplinary Center for Bioethics on the main campus, and he has more than 20 years of experience as a clinical neonatologist, actively involved in the training of fellows and residents in the newborn ICU, and 20 years of experience in clinical ethics consultation. Dr. Mercurio received his undergraduate degree in biochemical sciences from Princeton University and his MD from Columbia. He completed pediatrics residency and neonatology fellowship at Yale and received a master's degree in philosophy from Brown University. Dr. Mercurio has published widely on topics in pediatric bioethics and currently serves on the American Academy of Pediatrics Committee on Bioethics. We're very happy to have him here this morning and to comment on our case. And with that, I'll turn it over to Dr. Sue, who will present the first half of the case.
Good morning, everyone. And just to be clear, it wasn't me that was doing the transplant. It was Pat and Andre that just got out of the OR this morning doing a transplant. So that's right. That's why I look much more, I'm able to present this morning. I would not be able to if I were in the OR at 5:30. So my role here is to present the case and to also give you some context on what we're talking about with liver transplantation and biliary atresia. So without further ado, our patient was an 8-month-old male who had end-stage liver disease secondary to biliary atresia. He was of Somalian descent. Both parents were permanent U.S. residents. His diagnosis was made at 9 weeks of age, and the Kasai procedure was performed as a Kasai portoenterostomy, which is a palliative procedure for biliary atresia to attempt to clear the jaundice and establish some biliary connection that will allow drainage. 40% of these surgeries are not successful, and it has to do with the presentation of disease and how severe the disease is when it presents. So, like 40% of these surgeries that are not successful, this patient's portoenterostomy was not successful, and he had developed progressive liver disease and was then evaluated for liver transplant at 5 months of age. At that point, a liver transplant was recommended. So when our team talks to a family, parents, about biliary atresia, we try to drive home 3 points. One is that a child with biliary atresia who does not have clearance of jaundice and does not have established drainage from the liver through a Kasai develops end-stage liver disease and 100% mortality in early childhood. So 100% of these children will die without a liver transplant. The second point we have is that with liver transplantation, these children can do very well. And at our center, we've done 88 cases since 1991, the inception of our transplant program. All of our children who have been transplanted for biliary atresia have survived. You know, in my heart of hearts, I do believe that our transplant center is the best. But this isn't something that is unusual. Good results with biliary atresia and liver transplantation are seen across the country, internationally. So the Studies in Pediatric Liver Transplantation Registry was established in 1995 to prospectively follow children who had received liver transplants. And biliary atresia is the #1 indication for pediatric liver transplant, so we have a lot of numbers to back this up, and results are good across the country and internationally. And this is from data from 45 centers in Canada and in America. Patients do well. But there is long-term morbidity, okay? And the long-term morbidity is related to what patients now have to have what is akin to lifelong immunosuppression to maintain their graft. So one of the complications of liver transplant is PTLD, or post-transplant lymphoproliferative disease. And in this same database study that has followed children who've had liver transplants, they found an incidence of tissue-proven PTLD in 6% of 5-year survivors. PTLD is treatable with attention to immunosuppression, preventable with surveillance for viruses that are associated with PTLD, and with collaboration with our hematology oncology colleagues to establish good treatment strategies for this disease. Nephrotoxicity is also reported in long-term transplant survivors. The data is variable, so ranging from one single center study of 10 10-year survivors found a 77% incidence of stage 2 chronic kidney disease, which is defined by a calculated GFR of under 90, to, in the split database, 5 and 10-year survivors seeing an incidence of nephrotoxicity between 9 and 15%. So we know that nephrotoxicity exists, but we can't predict with certainty, what the actual incidence is. Also associated with the long-term immunosuppression are developing cardiovascular risk factors. So developing dyslipidemia, glucose intolerance, and increased BMI in 13% of 5-year survivors, also from our split data. Growth continues to be an issue with height below the expected standard population. But this is directly associated with the ongoing use of steroids at the time of assessment. Across the country and also at our center here, we've implemented steroid-free protocols that can improve our catch-up growth and linear growth impairment in this population. Health-related quality of life studies looking at the same split database have found that health-related quality of life is diminished compared to a normal healthy child, but we don't know why that is. And as we have continued to improve patient survival, continued attention is being paid towards improving the quality of that survival in these patients. So Pat, I'll hand it off to Pat to present the rest of the case.
Good morning. I'm Pat Healy for Transplant. So actually, after an introduction like that, which actually all the parents and patients who are being evaluated for liver transplant do get the same sort of education and introduction to transplant and outcomes. It's hard to believe that anyone would refuse after getting the information from, as Evelyn delivered it there. But this family was very troubled by the whole idea, and they refused the transplant initially. And at the time, they felt that the best thing that they could do at this point was just to go home. Actually, they wanted to go back home to Somalia, and so they did. And interestingly, on our side, it actually came up that should we actually let them leave, because they were inpatients, but we did have a lot of discussion about that, and but felt that it was right for this family to be able to go home, but then we honestly thought that we probably wouldn't see this child again. And then 2 months later, the child showed back up in our emergency room. At this time, the child had ascites and peritonitis, bacterial peritonitis, and was clearly had progression of the liver disease from jaundice and to end-stage liver disease. So at this point, this child is much sicker, much more acute, much more end-stage, and and was reevaluated, updated their evaluation, and again, liver transplant was recommended. So our transplant evaluation includes a social work evaluation. It's a very specific, for transplant-specific things, looking for family dynamics, family makeup, support, ability to follow the regimens that will be needed for to maintain the graft, to support the family if they don't have resources. We have options for sources of funding or other resources that we can try to make available for them. If they don't have insurance, we try to help them get insurance. So this family's pertinent social information was that they're here in the U.S. on a visa. Dad was employed and actually had a good health insurance plan. Father was well educated. He did most of this. He spoke English well, and he did all of the speaking really when we would see them in the hospital. Mother doesn't speak English at all, and we would need a Somali interpreter to speak with her. They have extended family in obviously in Somalia, but there was an aunt who lives locally, and she was frequently with the family in the hospital, and she was in the position as sort of an intermediary between the family, the mother particularly, and our team. So they were concerned that if they returned to Somalia, that Dad's job would be in jeopardy, but he has a job here with insurance, so that was keeping them here. So now it was clearly obvious to them, clinically, that this child was actually dying, that this biliary, all these predictions of worsening clinical status were right in front of them. So this was a failed Kasai. This was so they were coming to the realization that really now is the time. Transplant is really the only option, but is it really going to work? Why would we put our child through this kind of suffering when he's suffering enough? They're also concerned about the quality of life after transplant. Is he always going to be sick? Is this what he's going to look like for the after transplant? And he's always going to be on immunosuppression medicines, which may put you at risk for being sick. Father, very practical, an organized, bright guy, very concerned just how's this going to affect our finances. We're on good footing here, but not solid footing. We're not from here. I can't lose my job because of this or have to be in the hospital for long times away from my work. typically, if somebody lives away from the Seattle area and they're here for a transplant, we tell them they probably are going to need to be in the Seattle area for about 2 months. And 3 or 4 weeks might be in the hospital. The other 3 or 4 weeks would be in local housing. So, mother also expressed concerns just about, well, if proceeding with the transplant is actually against our culture, is this going to stigmatize our family, our child, when they go back to Somalia? How is our family at home going to think about what we did, or what he's been through? And they very clearly, mother expressed her belief that God has the final decision in this situation. So they were together in refusing the transplant, but mother was more adamant. And since she was the primary caregiver, father was respectful of that and felt that it was really important to defer to her wishes. I think he could maybe intellectualize and see our point from a intellectual standpoint, but what their belief was and what their real feelings were not to consent to the transplant. So despite numerous conversations with the parents, social work, we had a cultural navigator that also helped us out, try to understand this family, try to help them understand our perspective, the transplant perspective. Parents were opposed and wished to go home, wished to take their child home. And at that point, while we had talked about it quite a bit along the way, at this point we did ask for an ethics consultation. Along the way, interestingly, another thing that seems to be associated with a lot of ethics consultations is there was a lot of difference of opinion in the teams. Some of the nurses were upset that the family wanted one thing, the team wanted another. Some of the physicians, the residents on the different teams that are rotating through have their own personal approach, understanding, and opinions, but they were all the way across the board. So the ethics consultation was done. So the questions that were facing the team included these. Should the medical team honor the parents' wishes or seek to override their refusal and go ahead with a transplant? Now, as clinicians, as Evelyn said, we think we understand biliary atresia pretty well, and actually we have a very fair system, I think, in this organ allocation, particularly for livers, so that we can, if the child is urgent enough, I think with pretty good degree of certainty, within a few weeks, probably be able to get an organ that's a good organ that we would expect would work. And we can appropriately prioritize this child's clinical status so they would have access to good organs. So that's our perspective, that we believe that we should be able to, that this child should survive with the liver transplant. But then another question was, should the team seek a CPS referral and evaluation? And one other broader question is, how is refusing an organ transplant, solid organ transplant, similar to or different from other refusals like blood transfusions in the Jehovah's Witness population or non-Jehovah population, or refusal of chemotherapy? Another question, there are many patients on the waiting list nationally who don't have immediate access, and still there is a small but real death rate on the waiting list. Now, if you have patients that, is it right actually to push a liver transplant on an unwilling family when there are so many other willing and waiting families on the list? Now, how does that factor into the decision? So we called in our ethicist. Dr. Mercurio?
Thank you, Pat and Evelyn. Let's see if I can do this. There you go.
Thank you. Thank you so much for the kind invitation, and I do try to respond within 6 months whenever there's an ethics consult, so I'm glad I can be here to help, so that we can leave some time for conversation. Let's get to it. There were a few questions that were laid out, and we're not going to be able to get to all of them in detail, but I think the fundamental question that was laid out to me and presented was, what's the threshold beyond which parental discretion should not be permitted? At what point do we say to the parents that, no, your refusal is going to be overridden, or we're going to try and override? And that, in philosophical terms, begs the question. And it's different than in our common use. Begging the question means one thing. To an ethicist or a philosopher, begging the question means you assume something has been shown to be true that has not been shown. So it begs the question when we say, what is the threshold beyond which? It assumes that it's been shown that there is some threshold, which takes me to Brown University, where I studied philosophy, which you see there, which takes me to my first day in grad school, where I was already a 40-year-old, and someone asked me, what are you doing here? And I said, I chair an ethics committee. She was a senior professor. She was a full professor. I chair an ethics committee, yada, 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 and so I'm trying to learn better how to handle these problems. And she said, well, that's just ridiculous. She said, physicians should just do what they're told. And she wasn't kidding. She wasn't kidding. And you should be aware that that's one point of view. So perhaps one point of view that we are assuming that there's some threshold beyond which what the parents ask we would seek to override. We all assume that, recognize that in the greater world that may not be recognized as clearly the case. Note the Roman columns in the building at Brown, which was fortuitous as I was writing the talk, because of course in Roman days the father did indeed have discretion to the point of life and death over his children. Just like he had over his cattle and over his chickens and everything else, he had the same discretion over his children. So in another place, another time, perhaps even other places in this time, there's no such thing as what's the threshold. But we're going to start with the assumption that there is a threshold. And we're going to discuss this case. I'm not going to answer the question for you. I will, however, answer it for me. And I hope that the way I answer it for me helps you answer it for you. And I will give you an opinion at the end, I promise. Obviously, we'll talk about this case, but I'm hoping that the way we approach it has broader implications. So if you ask a simple man a simple question, you get a simple approach. Here we go. I would suggest we think about this transplant or any therapy that we're considering as being along some continuum, something that is, by our light, some things are morally impermissible, some things are morally obligatory. If, for example, you see that transplant as morally obligatory, that means we have to do it. And so if the parents say no, we have to take it to the judge and get past that, but we have to do it. And there's a lot of stuff in the middle that's morally permissible, but neither impermissible nor obligatory. And under permissible, I see inadvisable, unclear, and advisable, kind of this spectrum. And put quite simply, don't offer or don't do what's impermissible, do what's permissible, or offer, what's permissible. And when I say no savviness requirement, which means the parents deserve to know what's on the list of what we consider permissible. So if, for example, not providing a transplant is something that you think is permissible for them just to take this child home and let him die from his biliary atresia, they deserve to know that that's an option. But I think we should do what we see as morally obligatory. And we shouldn't conflate or confuse advisable with obligatory. There are some things, right, that we think this is really what you should do, but when push comes to shove, we're not calling the judge. This is something you probably really shouldn't do, but when push comes to shove, if you decide to do, we're not calling the judge. So we're looking for those thresholds. And there are, of course, two thresholds, right, between impermissible and permissible, and between permissible and obligatory. It's the threshold on the right that we're trying to figure out, that we're looking for. We get it that it's advisable. This kid should have a transplant. But is it beyond advisable? Is it actually morally obligatory? So three possible approaches to this. There's many others. Three possible theoretical approaches to this. And I know this is why people, when they hear an ethicist speak, or a student of ethics like myself, they want to shoot themselves. This won't take long, I promise you. And don't shoot the speaker if you're going to shoot someone. But three possible ways to approach this. There are many others. One is a consequentialist approach, which means, well, let's just take a look at the two possible approaches, force the transplant on the family or don't, and compare the outcomes. The other is a deontological approach, which really is an approach that considers things beyond the outcomes and considers our duties, our obligations, as well as the rights of the individuals involved. And the third is an approach called casuistry, which we use a lot in medicine, which is used a lot in law, where we consider analogous cases. And I think Pat, alluded to that a little bit when he said, well, how does this compare to blood transfusions and chemotherapies and things like that? So looking at these and thinking about these quickly, let's do a consequentialist analysis. In the time we have, we recognize that far more thought actually went into this by the ethics committee here, I have no doubt, by the clinicians who are caring for the child. But just to give you an overview. So what happens if we force a transplant? There's a certain right to parental authority that is denied. And that right to parental authority is huge. I'm guessing many people in this audience have children. And you recognize how very important it is to the way we live, to the fabric of our society, that parents have control over what happens to their children. Well, that right is going to be denied on some level if we take it to the judge trying to overrule what the parents have asked for. There's some sense of a cultural violation also. These folks are from another land. They have different ways. Are we really forcing our ways on them? And to some extent, the answer is yeah. Family integrity upset. By that I mean the family's ability to kind of control how they want to live. What about the dad's job? What about having to do this? What about the way the family chooses to operate? And who's in charge of the family and how we're messing with all that? The other outcome is, as we saw from the data, the child probably survives. Now, on the other hand, if we agree to the parental refusal, the parental authority is respected. There's no cultural violation, though, except perhaps for some of the clinicians who may feel this is a cultural violation. The family integrity is preserved, and the child probably dies. So when you look at this, when we look at the consequences, you have to weigh these, and there are certainly other consequences on both sides. We weigh these. We say, oh, on the one hand, on the other hand, and it sounds a little bit like Tevi from Fiddler on the Roof. When he's trying to figure out if his daughter should be able to marry that guy. Well, on the one hand, if we do this, and on the other hand, she loves him, but on the other hand, and he goes back and forth, and which is why I dressed as Tevi today. Ordinarily, I look like a young Robert Redford, but today I came as Tevi to make this point. For those of you who remember the play or the movie, how did Tevi, this is the second daughter, not the first one, how did Tevi end up coming to the conclusion? He said, on the other hand, he said, if I do this, he said, this goes against my faith and what I believe in. And then he says, on the other hand, well, no, there is no other hand. What you saw in that brilliant play was a man saying that, well, there's something beyond the consequentialist analysis. There's something beyond these arguments. And we as physicians often see that there's more to it than just adding up the things in the different columns. There are some things that we owe our patients. There are some obligations that we have. These duties, this deontological approach to ethical problems is something that so many of us adhere to. We have obligations to our patient. One of our obligations may be to provide them with care that's likely to save their life. We have obligations to our parents, and they have rights. Rights and obligations are two sides of the same coin. The parents have a right to control what happens to their kid, and we have a right to, and we have an obligation to respect that. We're trying to weigh these different rights and obligations as we do this. I would suggest to you that special relationships bring on special obligations. Now, there's the parent-child relationships. The parents have special obligations to that child, of course, that they don't have to a child who lives 500 miles away. Moreover, I would suggest that we as clinicians, when this child is within our facility, we have special obligations to that child as his doctors. We have special obligations. So what trumps our obligation to respect the parents as parents? I don't think we ever stop respecting them, but our obligation to obey them, if you will, compared to our obligation to the child. You have to decide what trumps. There's the physician right there. She's trying to decide. I don't know what she's smiling about. This is serious business. But physician, she has an obligation to the patient. There's her patient. There's the family. I'm making this up. This is not the real family. Someday I'm going to do one of this, and people are going to say, that's my cousin, because I steal all this stuff off the internet. That's my cousin. The point being, there's lots of obligations and rights at play here. And I will just suggest to you, for me, as a physician, perhaps for you as a physician, as a nurse, as a social worker, perhaps you see your special obligation to that child who has a fatal illness. Perhaps you see that special obligation and that child's right trumps the parents' rights, which are significant, and our obligations to the parents. For me, I would say yes, the child's rights trump in that setting. What about a casuistic approach? Think about some analogous cases. A newborn with bacterial pneumonia who's on mechanical ventilation. The vast majority of these kids survive, by the way, and the vast majority of these kids after the newborn period are just fine. I've been in a situation where a family refused mechanical ventilation, perhaps because they didn't believe me that the baby was going to be fine. That's what they said about Uncle Henry. He was on a machine for 6 months and he died anyway. This is a case where we're pretty sure of the outcome and where the road is not that long and difficult. Good prognosis, not such a difficult course. This is a case where I would suggest to you, many of us would be likely to say, no, we're going to have to insist. We're going to have to seek to overrule the parents if they refuse that mechanical ventilation. What about extreme prematurity? This is a fascinating example because we know that that's not going to be a week on the vent and antibiotics and you're going to be fine. This is going to be a long, difficult course. And then potentially a lifetime of disability. Most of these kids are going to do well, but there's a potential for a lifetime of disability. What do we do with these? Well, interestingly, what we do with these is we say, we know the course is going to be difficult. We're getting a little bit closer to an analogy with the liver transplant. The course is going to be difficult. And the outcome, what about the outcome? Well, the outcome varies tremendously. At 23 weeks, it might be 25 to 40% survival. At 26 weeks, it might be 90% survival. Rough numbers here for the sake of this conversation. And indeed, the way we manage extreme prematurity in most American hospitals, and I suspect here too, is that somewhere around 23 weeks, things may vary week by a week in either direction at different hospitals, somewhere around 23 weeks, we don't force it. Somewhere around 26 weeks, we do. In both cases, it's a long, difficult road, but the prognosis, as the prognosis gets better, our feeling that we really need to force this, that the child's right to the treatment becomes larger and larger as the prognosis of the treatment becomes better and better. And lastly, for our analogous cases, I want to consider intestinal transplant for short gut. And I faced this as a visiting professor at another place where I got to meet with the residents, and they said, we want to present a case to you. They presented a story of a child who had volvulus, had the entire gut removed, and survived, and now this kid's on TPN. And the question they asked me, this is just about 3 years ago, the question they asked me took me totally by surprise. They asked, so are the parents obligated to go for transplant, for intestinal transplant? Now, typically the question you get asked is, so is this something we should even offer, or should we just let the child die? These residents, the younger generation, wanted to know, is this obligatory? Is this, no, not permissible, not even advisable, but in fact, obligatory? And it's a fascinating question, and I think that the answer to that ultimately that most of us have achieved is either we don't try, or most consider it to be. In fact, I did a study polling lots of neonatologists and lots of pediatric surgeons, and over 90% of us think that it is permissible, which is to say it's also therefore optional, and the parents can opt out. Now here we have a long, difficult road to be sure, but we also have a prognosis that's a little less certain. The prognosis, once these kids get their transplant, is surprisingly good. It's like 60% or 70% 5-year survival for a volvulus patient. But what no one knows is what percentage of these kids die while they're waiting to get the transplant, these babies who would have this diagnosis. And so we have a prognosis that's a little bit more unsure, unclear. It's not as good, but it's also unclear. And we have a difficult course. And based on that, in this case, we give the parents a choice, generally. So depending on the prognosis and on the difficulty of the course, sometimes we think these things are obligatory, and sometimes we don't. Now, as the old song says, it's a long way from Seattle to Somalia. And no, there's not really a song like that. The point being that the cultural difference here looms large. And there really isn't time for me during this few minutes I have to address this at any length, except to acknowledge it and to recognize it is terribly important to respect, of course, all the parents we encounter, and particularly to be sensitive to and respect when they come from a very different culture than ours. However, I would suggest to you that that does not necessarily mean respecting an individual, respecting that individual's culture does not mean that when they arrive in Seattle, you are obligated to do as they would do in their home country, or wherever that may be. I don't think that's the case. I think that, in fact, you have certain standards which you should maintain, and a child's rights in Seattle don't vary depending on the parent's country of origin. So by all means, respect it. By all means, consider it in the discussion. But this child's rights don't disappear because of where his parents are from. Now, religious or cultural or philosophical objections, there was a brief allusion to that. The mom thinks, we should just let God decide this. There are certainly some cultural concerns. This is a statement by the American Academy of Pediatrics, the Committee on Bioethics, which is brilliant, I think. It is one of the more brilliant sentences that have come out of the Committee on Bioethics. And I say this because this is before I was on the committee. I don't even know if Doug is here. I think Doug may have been on the committee when this was written. But this, I think, really helps us to understand, to get a handle on the thresholds. And this is written with regard to religious objections, but I think it speaks to cultural and philosophical objections as well. The children, regardless of the parental beliefs, deserve effective medical treatment when such treatment is likely to prevent substantial harm, suffering, or death. So the child who comes to you and has a twisted ankle and it's a soft tissue injury, and you say to the parents, give this kid ibuprofen around the clock for the next couple of days, and they choose not to, I would suggest to you that that child doesn't have some kind of sacred right to that ibuprofen, because the ibuprofen is not going to prevent substantial harm, suffering, or death. It's going to reduce the pain a bit. We think it's advisable, but is it morally obligatory? I would suggest it's not. With some chemotherapies that are potentially life-saving, but they have maybe a 10% chance of working. Here again, likely to prevent substantial harm, suffering, or death. So we're looking for something that is likely to work, and it's going to prevent something substantial. In the case presented, we saw the wonderful statistics that you have here in Seattle. It's likely to work, and it's likely to prevent not just substantial harm or suffering, but it's likely to prevent death. So I think that if we think of this as a threshold for, or as some guidance for when we're going to step over that threshold with the parents, I think that's very helpful. And I do think that this case passes that threshold. Now, you can't talk about any of these things without talking about the patient's best interest standard, which is kind of like the holy grail in pediatric ethics. And it's sometimes oversimplified, but basically it comes down to this. When somebody has to make a decision for someone else medically, anybody, whether it's your grandfather or your child, if there's someone who can't speak for themselves, a surrogate decision maker speaks for them. What we prefer is that the surrogate decision maker decide based on what that individual would have wanted, called substituted judgment. When the individual never developed preferences, for example, a small child like this, then the next standard we fall to is the patient's best interest standard, where we expect the surrogate decision maker to weigh the benefits versus the burdens to the patient. It's the patient's best interest of the proposed treatment. Now, of course, this is invariably subjective. We have the benefit of, likely the benefit of survival, the burden of perhaps the need of long-term immunosuppressive therapy, the burden of a long hospitalization at the outset, and so on and so forth, those things that were laid out a little bit at the outset, to weigh the benefits and burdens. This is what we'd like the surrogate decision makers to do. And our role is basically to step back and let the surrogate decision makers decide. But once again, there's going to be some threshold. Sometimes they decide things we say, well, that's not what I would have chosen. And sometimes they decide things we say, whoa, that is really a bad idea. That is really, what they've chosen is clearly opposed to the child's best interest. So we need to step in and seek to override their decision. It's subjective where you reach that point. This whole threshold business is terribly subjective. It's subjective where you reach it. Do you think that they've reached it in this case? There's another aspect to it which gets talked to a little bit less, but which is terribly important. Patient's best interest refers to what's in the best interest of the kid, not everybody else. But there are those who would argue, those who have argued, that we need to consider the interests of all those who are going to be affected by the decision. So it's not just the kid who's going to be affected, it's the parents, it's potentially siblings, it's, there's a lot of people that can be affected by this decision. We don't want to force this on people if it's really going to be horrible for them, for their family, if it's going to be extremely difficult for them. Is it okay to broaden that circle, go beyond patient's best interest to family's best interest? My humble opinion, this is the single biggest question in pediatric ethics. Can we broaden that circle and consider the interests of others? Indeed, go even beyond that and consider the interests of society when we recognize more and more our limited resources. Lastly, there's something called the harm principle, which is different in philosophy and in pediatric ethics. This was best explained by Doug Diekema, who it's probably worth taking 10 seconds to point out. There's an old saying that the prophet is not without honor except in his own country. So I don't know how much around here people think about the stuff that people like Doug Diekema or Ben Wilfon write or say, but elsewhere in the country we pay very close attention. Doug has written and participated in a lot of policies nationwide that a lot of us pay close attention to and have a great deal of respect for. Doug has written very well and pointed out that We don't really expect parents to decide what's in the kid's best interest, as long as their decision keeps above some threshold of harm. Again, back to these thresholds. Again, okay, fine, are we below that threshold of harm? Have we finally said, okay, this decision is not just against the kid's best interest, but now we've really done that? You don't have to send your kid to private school if the public school is reasonably good. It might be in his best interest to send him to private school. But if you want to save that money for something else, and you can send him to public school. You can't tie him in front of the TV and just put Cheerios in front of him all day. That's below the threshold of harm. Is this below the threshold of harm, denying this kid the treatment? Patient's best interest is going to play an important part in any of these decisions. Because ultimately, this is like a slide I say, you have to, if you say, did I misspell anything in this thing? And the computer says, no, you spelled hat perfectly correctly. That's great. All right, well, we'd hate to put them through so much because it's a long, hard road. This is something we'll hear. One thing we heard from the outset is good people will come down on both sides of this question. Good people, thoughtful people. And one of the things we'll say is, we'd hate to put this whole family through all this because it's such a long, hard road. The transplant, the post-transplant care, then the years of care potentially needed, and the possibility, not high, but the possibility of significant medical illnesses that can be seen subsequently. So let's take a good look at the hard road. Any hard road that we face in life, but we face in medicine. If we're trying to decide how relevant that hard road is, that long road is, we ask, well, how long is it? How long is the road? How difficult is it likely to be? And in this case, for the child, and let's even also consider for the family. What are the chances we're going to reach the destination? I'm talking about any road. We're deciding whether to take this this is the Wilfon Turnpike here. We're deciding, should we take this road? These are the things we think about. What are the chances it's going to get us to where we're going? Well, we learned that the chances are actually extremely good. You've got a 100% survival here with liver transplant. What are the alternatives and their likely outcome? Particularly alternative routes that may be able to help us avoid our biggest concern, which is a lack of respect for parental authority. Is there a way we can have the parents do what they want to do and still get us to where we're going? It seems to me the answer to that, based on the data we heard, is no. Is no. If we don't do the transplant, this child's going to die. And it gets us to the last and most important point about this case, which is how sure are you about your data? Are you really sure this road is going to get us where we're going? Are we really sure that the other roads won't? One of the things about this case, which I think is really noteworthy, is the answer to that question is, yeah, we're really sure. I have to tell you, so often in ethics consultations, you ask people to say, well, if we don't do this, he's going to die. And you say, really, and what's that based on? And I read it once in People magazine. Or, my professor told me this back in medical school. No, we've got some serious data here that we're looking at. So I think that one of the great strengths of the argument in favor of transplant is how sure you are about your data, both if you do and don't do the transplant. All right, time to wrap it up. What's the difference between a philosopher and a physician? I can tell you this, having been a physician surrounded by philosophers for some years going to grad school, is so you come to a road where you can't really tell which you should take. It seems like equal paths. It seems like equal paths. So what a philosopher will say is, it seems like equal paths. Okay, so you could go either way. Well, supper's calling. We're out of here. That's not a choice that these guys had. That's not a choice that you as a medical community had. You've got to make a decision. You can't simply say, we don't have enough information, we haven't talked about it. You've got to make a decision. So I will, in that spirit, make my decision. There's that threshold we're after. I consider this, based on all of the arguments I presented, I would say good people could fall on either side of that threshold. Some might think it's advisable but not obligatory. I think it is obligatory. Each of the analyses, the consequentialist, the deontologic, and the case analysis, I think all of these point toward this being obligatory. The single strongest argument against it is respect for parental authority, which I think is huge. But in this case, I don't think it outweighs this child's right to a life-saving treatment. And then finally, I would point out to you all that I don't even think we need to locate that threshold. That threshold is hard to find. But in analyzing this case or any case, you don't have to locate it. What you have to do is just figure out which side of it you're on. which side of it the proposed treatment is on. That is to say, if you ask me, well, exactly when does parental authority have to take a back seat? Well, I say, I can't tell you exactly when. If you ask me exactly when, what's the exact moment that day turns into night in Seattle on May 16th? I'll tell you, you know what? I can't tell you the exact moment that day turns into night, but I promise you that right now it's daytime. I know which side of the threshold we're on, even if I can't locate that threshold precisely. In like fashion, I would say to you that we don't have to know exactly when it's okay or obligatory for us to try to overrule a parental decision. We have to just figure out if the question before us puts us on one side of that threshold or the other. Personally, based on everything that was presented to us, as well as the ethical analysis, I suggest to you that an attempt to transplant this child through legal recourse, if necessary, is obligatory. And I thank you very much for the kind invitation.
Very quickly, we just thought we would share the outcome of the case with you, and then we'll take a few questions.
I will skip through this
Oops,
one.
sorry.
That's all right. Oh, here we go. No. Oh, sorry. Oh, here we go. Slideshow. Okay. There was dissent, but was not so well delivered as what we just heard. It was a wonderful discussion of our dilemma. We did get CPS involved. CPS referred us to the court, and the judge ordered that with CPS custody, there was a court-appointed medical guardian, and that we were then allowed to proceed with transplant. The aunt actually played a very good, very key role in dealing with this family and our team, and supportive, and she was very, very supportive and a communicator during the course of the transplant and the post-operative period. So the transplant was performed. The child did well. The aunt remained active in the care, coming to clinic. Actually, mom and dad also ended up coming to clinic. Now the child this is 3 years later. Child is doing well, 4 years old, on a single immunosuppression agent once a day. I think has had 3 or 4 hospitalizations after transplant, all within the first year. Has not, and the parents state that they are very happy with the outcome. Let's see. I think at this point, what we should do in the interest of time is just open it up for questions, Dr. Pendergrass.
Microphones?
Yep, we've got
They're available
microphones
for you?
on both sides, and we can bring one to you if you like. Any questions?
So Mark, thank you for that wonderful talk. We're all ethical judgments by the committee, so straightforward and able to be clear. First of all, I want to thank Jeff Sconyers and Deborah Godfrey for their support of this. It's really, Jeff's our general counsel at Seattle Children's and highly committed to the ethical treatment of kids, and they support this. I want to thank them. I hope they're here, and if they are, I want to acknowledge them. I have a question about the threshold, and it may be, you answered, you're either on one side or the other, but being a nephrologist and early in the days of transplantation when some of the outcomes weren't so clear, it was often a big dilemma when the parents were not engaged or if there had been a history of abuse. In other words, when you sort of decide to step in and take that next step, and the threshold is often different how you feel about the parents. And this is a wonderful family. They're intelligent. This made it very hard, I'm sure, because of your respect for them. But there are also situations where the child doesn't necessarily have a good parental advocate. And it seems like that the threshold moves considerably based on that support system for the child in terms of how quickly you make these decisions, and interested in your opinion.
Well, I think you're right. I think that threshold can move, based on all of the information we have, and the relevant information is information about the family. I think the most important thing as the threshold moves for any treatment is the prognosis and the benefit burden analysis. But also there's things that are just our moral judgments that move it. I will tell you that surgery or ECMO for a child with Down syndrome was on one side of that threshold by the lights of most physicians 30 years ago, and is now on the other side of that threshold by the lights of most physicians without any new data, without any change in the technology, that these things move sometimes just because of our attitudes. So lots of things are going to affect where we are on that, and certainly where the parents are will affect it to some extent. However, I would caution us all about it, caution myself about that. I don't think that a child's right to life-saving treatment depends on who his parents are. Now, that's an oversimplification, but it nevertheless stands. That who the parents are and how they're going to be able to participate in the care may influence the prognosis, so that's appropriate. I don't think it necessarily influences the child's rights, which to me is what has priority in this setting. What should we do?
I have a question sort of related to that. One of your last slides asked how good our data is going into this decision making. And with your first framework for how to think through this problem, I think it was the consequential framework, looking at the outcomes. A lot of the outcomes from the family perspective were negative. Yet in the end, with a successful surgical and medical outcome, the family seems quite happy. So it seems like the data going into that decision making from the family perspective wasn't as good as, or wasn't as reliable as we'd like in terms of how the family would, the experience the family would get if we went against their wishes. So I guess my question is, how best do we figure out at the beginning what really is right for the family in addition to the patient? Because that weighs at least some part into the decision making. In the end, the family's happy despite the fact that we went against their wishes, and that's not how the framework was initially listed out.
Well, I think that's all part of the data that we need, and it's data that's extremely difficult to come by, and it's data that I would say as a physician that I am extremely vulnerable. While the parents don't necessarily know what they're getting into, the truth of the matter is, as a neonatologist, more often than not, I don't either. People say to me, do you know what it's like to have a child who's had a grade 3? No, I don't. I've read the follow-up stuff, I talk to people, but we make decisions, we make judgments based on data of varying quality. Your point is right on the money, which is to say that the data about the survival or what percentage of these kids are going to have medical problems, these we can get a better handle on, the data of what's it really going to be like for this particular family. And we need to do the best we can. This is because we're going to come to that fork in the road, and we're not philosophers, we're physicians. We're going to have to make a decision. So we have to do the best we can to figure out how this is going to affect the family and how much that should influence our decision. It's an imperfect process, to be sure, and you're right, that's an important part of the data. Ben?
And Mark, thank you for your presentation. You described this as being obligatory, and so my question for you is, in a context like this where you believe that the intervention is obligatory, how does that change how you would approach the family? Would you still explain the data and ask for their permission, or would you just tell them that we have to do this? How do you?
In the interest of time, I'll answer it directly and simply, and it will, of course, be an oversimplification. I think that one of the biggest mistakes we make as physicians is we give people choices where there shouldn't be choices on both sides of the spectrum. So I don't go to someone, again, I'll speak as a neonatologist to try and be clear, I don't go to someone who has a child born at 30 weeks with RDS and say, you know, I'm thinking maybe we should put this child on a ventilator and I'd like your permission. I may need their consent, but I tell them this is what we need to do and this is what we're going to do. If they then object, if we have to go to a court, we will. If there's no time to get to the court, I'll put the child on a ventilator. In like fashion, when a child is born at 20 weeks, I don't go to the parents and say, I don't think we should try to resuscitate this child. I need your permission not to do CPR. I don't do it. I think it'd be morally impermissible to do that to a child born at 20 weeks. And I think so if we've decided, and I told you, I decide this for myself, I didn't decide it for you. If you decide that something is morally obligatory, I think it should be presented that way to parents. I think it's fundamentally dishonest to tell people. Now, I think it is dishonest to tell them, we're going to need your permission to do this, but we feel very strongly that this is what's right for the child, and if we don't get your permission, you know, we're going to seek it elsewhere. 99 times out of 100, you don't have to phrase it that way because the parents are right there with you. But for the one time out of 100 where they're not, first you try to convince, you use a little bit of patience and compassion. This is their kid who's terribly sick. We do these things, but when we fail at using that route, that, yeah, I don't think we should say, well, this is really a choice you have. In general, if it's not a choice, I don't think it should be presented as a choice, whether it's impermissible or obligatory.
Hi. I'm just wondering whether you think the justice issue should be considered in this case at all. The fact that somewhere in the country, a family who's desperate for a transplant, their kid could die on the list, and yet we're compelling another family to take one initially against their will.
That's a hard question and a really good one. And we didn't get too deeply into it, but I've thought about that because I think that that's a really important and good question. On the one hand, I think that this child's right to life-saving treatment does not depend on his parents agreeing to it. On the other hand, I think that if we could imagine a scenario where all things are exactly equal, except that these parents want it and these parents don't, then as I go through this whole analysis, if I say, well, I'm going to have either one dead child, either way I'm going to have one dead child, and I'm going to have one dead child and all the parents feel like their wishes were respected, or one dead child and half the parents do and half the parents don't, then I think you could make that argument. That argument has been made specifically with liver transplants, but first, I'd want to know proof. I'd turn to my friend Pat and say, so Pat, how often does this happen, that these kids die? Is that really an issue with this? So if we do like philosophers do, if we put ourselves on an island with maybe a trolley car someplace and try and sort this out, that I think perhaps there could come a point. But I think there's a strong burden of proof on us that we're going to let this child die in order to save a different child. And to me, that's a secondary consideration. This child's rights, to me, are the primary consideration. Again, because this is the kid. I feel a special obligation. I realize if I were secretary of, or president or head of the UN, that I have an obligation to everybody. For me, I feel I have a special relationship with my patients and a stronger obligation for my patients. So I do whatever I can to get my patients what they need. Please.
So this was a fantastic case, but it's kind of unusual. I think a lot of times that we are presented more with the parents who are wanting to do everything for their child to the point of putting that child through suffering, especially in the NICU. So I think you kind of touched on it, but it would be nice to hear your opinion on how you guide the family through a place where the child is not going to survive. And we make excuses that the family needs time to get there. But at the same time, we're putting that child through a good deal of suffering. And by all means, 90%, we know 90% that this child is not going to make it. So I'm wondering if you might comment on that.
I would make just a couple of comments on that, because that's, as they say, a whole nother talk. And in fact, this afternoon, I'm going to give a talk on that question largely. But I would say just a couple of things. One is that if something by our lights is truly impermissible, it should be presented as such. I think we do families, and again, to use an extreme example to make the point, at 20 weeks, if a woman's about to deliver at 20 weeks, I could make the gods of informed consent happy and say to her, listen, I think we should make this child DNR. Can I get you to sign here? We're going to make this child DNR. Am I doing her a favor? Am I doing her a service by making her think she's deciding if her child lives or dies? I think I'd be doing her a terrible disservice. And I think sometimes in the ICU, we do our patients a terrible disservice by making them think they're deciding if their child lives or dies. However, and here there is another hand, and it gets to my point about the long road, how sure are we of the data? How sure are we of the data? You're probably familiar with a few years ago, the folks out at University of Chicago walked around the newborn ICU and they would ask attending, a resident, and a nurse just a simple question: is this child going to live or die? Is this child going to get out of the unit alive or not? And they asked, various people, and they did a whole bunch of stuff. They gave them chocolate if they would answer the question. And then they did. And then in the end, they added it up. So attendings, residents, or nurses, who is good at predicting which child's going to live or die? The nurses, right? Yeah, that's what everybody says. Wrong. The answer was none of them. And so while I'm confident that I can't save a child at 20 weeks, my confidence about a given child in the ICU sometimes is not so strong. So I have to ask myself, how sure am I about the data? And that influences where I might be on either side of the threshold. So it gets nuanced. But I agree with what I think is your general point, that sometimes we are certain, and at that point we give people false choices that I think just mess with their heads and leave them, I know from experience in some cases, leave them with some long-term damage, the parents I mean. Sir.
Thank you. That was a lovely talk. I'm wondering if I'll get chocolate if I ask a question.
Absolutely, but not from me.
Okay. Well, my question's about culture. You know, we're from Seattle, and we try to be really sensitive to people's culture. But what if these people were like the top 100th of 1%, and their lifestyle was jetting around the globe, and it was really inconvenient to need a liver transplant because it was going to decrease the number of frequent flyer miles they'd get? We would think that was ridiculous. But there are people who live like that. And so my question, and I know it's good to consider the family, but I think I come down on the same side as you, which is my obligation primarily is to the patient, because that's what I do. And so putting family culture, especially if we don't even understand it or don't know that much about it, but I just find that to be a very difficult thing because, again, sometimes, for instance, you know, a Jehovah's Witness family, and I don't mean any disrespect to any Jehovah, will allow a liver transplantation as long as they don't get a blood transplant during the procedure, and yet in utero the liver makes blood. So I'm very confused about that, but there are families that are very clear about that. So I just don't know where those things fall out.
I think that's a good point. And I think we're all struggling with that, and I think different, smart, intelligent, sensitive people will fall somewhere differently. Okay. I got you. Some tall people, some tall, thin people, some not so tall, chubby people may find themselves on the same page with this. Again, I think that's the fundamental question, is how much the family's interests count. That's the fundamental question in pediatric ethics as far as I'm concerned. And I think you and I are on the same page, which is that's something to think about, but the child's right to a life-saving treatment trumps that.
Yeah, just really in response to that culture issue, I think one of the points here is that our survival is so good in the US. Now, it would be a completely different issue if this family said, we are here for 4 months, you do a transplant, they'll go back to Somalia. That we won't have a survival, long-term survival, if they go back after transplant to Somalia. And so that's an important part of the cultural decision as well.
Thank you, yes.
And I want to clap for all of you being here. Thank you very much.